Hi guys, welcome to Dr. Gilead Show. Today is Thursday, March 30th, 2017. We are on WBGI Radio and also on FaceTime. Today we have a special guest, and it's always a pleasure. But before we go to the details, we always like to say, please do not use what you hear on this platform from the guest or from the host to make a diagnosis of yourself. Do not treat yourself based on what you hear on this platform. It's always good to see trained personnel so they can evaluate you and give the appropriate treatment. Dr. Gilead Show, the host, the producers, the guests cannot be held responsible for what you do based on what you hear on this platform. So please, it's always good to see a trained person to get the appropriate diagnosis and get the right treatment. All right, having said that, I want to welcome everyone back again to Dr. Gilead Show. This is a special mental health treatment, mental health program where we educate people on mental health issues, and we try to bring as many experts as possible. Today I have a special guest with me. As a matter of fact, two special guests, and these are great people. With me is Dr. Young G. Dr. G, you want to tell our audience about yourself, introduce yourself briefly.
Hi, hi everyone.
Now to speak up a little bit.
Yeah,
So they can
okay.
hear you.
My name is Young Ji. I'm a child psychiatrist at Kennedy Krieger Institute and also assistant professor at Johns Hopkins Medical School Psychiatry Department. I work at Kennedy Krieger school programs and see children who comes to the special education school program and do consultation and treatment there with the team.
That is good. Thank you very much, Dr. G. You're welcome to the show.
Thank you for the invitation.
Thank you. And right here beside me also is a special guest, Ms. Kelly Wright. Ms. Kelly Wright, tell our audience, our viewers, about yourself a little bit.
Good afternoon. My name is Kelly Wright. I am an educator for Prince George's County Public Schools, and I also happen to be the mother of a teenager who is on the autism spectrum.
All right, thank you. So, guys, we're going to talk about a special disease spectrum today, autism spectrum disorder. Autism is it's a very big one, which as a psychiatrist, I see quite some of these people with this diagnosis. So today we're going to talk about autism spectrum disorder, and I know that there are a lot of people there who either have family members or clients or patients who have this same illness, who may have questions. You can always call on 301-429-9247, 301-429-9247, or you can also send me a message on on Facebook. As usual, we answer those questions. If you have a contribution or you have a question, please feel free to send those to us, and Dr. G will be willing, and also Ms. Wright will be very willing to answer your questions. If you have contributions, it's also good to talk about it. All right, Dr. G, this is your little niche, and I know you see quite a lot of children with this diagnosis. What is autism spectrum disorder indeed? What is it?
Right. So autism or autism spectrum disorder is a disorder, a neurodevelopmental disorder, which means it occurs when the child develops their brain. It has characteristics, largely two aspects. One is social skills, including communication, like either verbal or nonverbal, or both.
Mm-hmm.
That's one aspect. Social skills deficit. They have difficulty social skills and communication skills. The other aspect is they have tendency to and preference to sameness. They like things same, things routine. In that category, they also have repetitive behaviors. Because again, this kind of same thing, repetitive. Also, because they kind of like the same thing, they tend to go to really detail about what, a few focuses that they like. If it's a toy, just one thing, one toy, or if it's a show, just one part of the show they watch over and over again, things like that. And in that, also in that category, kind of the same thing, the sameness, they have very particular likeness or dislikeness. So one of those are sensory issues. They can be very hypersensitive to light or noise, things like that, or texture, or they are very hyposensitive, like to pain and things like that. So again, like it's a spectrum. So you have a very milder child cases, or very severe children who has like all of this very severe. But social aspect, social communication aspect, and then the liking, the sameness, which what we called repetitive, restrictive behavior and interest.
Wow.
Yeah.
Well, it's a big one, and we're going to go into the symptom profile, how people present, and all that. But well, maybe Miss Wright, when we get into the symptoms, you are a school teacher. How often do you see kids with autism? I know you're not in special ed.
No, I'm not. I'm a general ed teacher, but based on my son, I guess I have a radar when it comes to certain things, like you talked about, the sensory aspects of it, because sometimes a loud classroom can bother certain children. So I look for the things that I see on a daily basis in children. Okay. And then, I can't diagnose.
Well, by now you should.
I think the educators, what you can do, particularly have more, sensitive eyes to catch. I think that expressing your concern or describing what you observe will be
absolutely.
important.
I have used that to speak to parents about what I see,
right.
Because we don't know.
Right, right. You can ask like the parent, did you notice this?
Yes.
Is there any other concerns do you have?
Right.
Things like that. Yeah.
Okay. So Dr. G, I mean, what could be the cause or risk factors for autism spectrum disorder? I overheard you talking about this prior to the show with Ms. Wright. Well, tell our audience, what will people want to know? People want to know what can I do to avoid this? So what would be the cause, or what could be the causes or risk factors for autism spectrum disorder?
Definitely. I think autism is kind of hard. They're harder concept to grasp. It's not like infection, which is easy. There's bacteria and you have this.
Yes.
So autism is complex disorder, complex brain disorder. So the cause is also very complex. And it's really hard to pinpoint like this is the cause. So we know, as you said, we know risk factors. So as I said, this is developmental brain disorder, neurodevelopmental disorder. So something, when brain is forming and growing, something happened, or continue to happen. So the causes that we know are the risk factors we know. Are some genetic impact. Some of these children, autism runs in certain families. Some families, so they have relatives have autism or other developmental disorders. So we know some genes, and then a lot of geneticists and researchers study number of genes. It's not even just a few genes. We know like hundreds of genes might be increasing the risk. So that's one aspect. We know some about genetic aspect. We know some about environmental risk factors. and Ms. Ryan was saying, what we know, some of the things that we know are very premature children.
Right, yeah.
Like, again, when the brain was developing, if there was just something didn't go well,
Right.
it could increase the risk.
Mhm.
Again, none of these are direct cause of it, but increased risk. So very preemie or very low birth weight could, in that population, autism rate is higher. And then parent age, particularly parental age and mother's age too. So when they are older, in that the children population, we see more autism.
So if the father is older,
yeah.
so there are possibly higher chances that, or if the father is older, there are more chances they could, the children could.
Right, again, this is risk factor.
Risk factor, yeah. So it doesn't mean that
Right.
if I'm an old man, if I have another child, is going to have autism, right?
That's not
So it's just that the
yeah.
possibility is
Right.
higher.
And the more risk factors you have,
Yes.
let's say in the family there's some autism, and then the child was very preemie, and then father was older, mother was older, all things kind of cumulatively together, obviously the risk will be higher. Although with just one risk, or sometimes some children we don't find anything, what we call idiopathic, we don't know the reason. So that's why when we talk about why is this happening, it's so hard to answer, how long I've been talking to answer this question. So, but again, multifactorial, and it's risk factors. There are certain things that you could do to reduce, but certain things you can't. Yeah.
Okay. I found this this statistic that talked about some neurobiological factors, things like if the child was exposed to some viral infection while in utero, while in the mother's womb, like rubella, which is not common anymore, rubella virus, and also some other diseases like phenylketonuria. So these are all some of the things that it's been shown that they could. Children that had those could also develop autism spectrum disorder.
Yeah, in some sense, anything that can affect the brain development could increase the risk.
Yeah. Okay. So what are the if a child has a brother who has autism, I guess there are higher chances of another child having it.
That's correct. Yeah, that's correct. And then if you have two siblings, then it goes even higher. And in that family, I would strongly recommend to see, geneticist, and see if you can kind of a little bit more narrow down what kind of genes might be there sharing.
Okay.
And then also counsel, okay, what's the risk for the next child if you want another child, things like that.
Okay.
So, yeah.
All right. Yeah, there it says 2 to 4 if you have family in a family where you have 2 to 4% of siblings, that there are higher, I think it says 50% chances of another kid having autism. Yeah.
So if you have one sibling that has, and the next if you have a child with autism, the next child having autism, a chance goes up high.
Yeah, much higher.
About 5% or so, and then if you have like 2, then it goes like, I don't know exact number, but like 10 to 15.
Much higher.
If you have 3, it goes up to like 25-30%, things like that. But again, certain families you don't have anybody with autism, but a child had autism. So nothing is like exact rule.
Right.
It's, again, risk factors. So,
right.
Yeah.
Okay. All right. So we talked about it. Anything in the environment other than what we just talked about? Maybe exposure to things. If mother is pregnant and has lead or something, do you think that can affect it?
That's very common questions we get, and then also the kind of connected with why is this more now than before, and people are thinking what's different now.
Right.
I was just talking to Ms. Ryan too that identifying environmental risk is even harder because it's hard to measure who's exactly exposed, how much, and and we need to have larger population to measure. Even if you are exposed to a certain thing, it doesn't mean that everybody will develop autism. So to have enough number to really study is that the cause or not, it's not easy.
Right.
So, well, what we know, obviously, any significant toxin in a higher dose, if you're exposed, that is concerning, because I think what we think is when brain is developing, I think what we are thinking is what's going wrong in autism is the connectivity, because in our brain we have lots of parts of brain, lots of the cells, nerve cells, like billions and lots of nerve cells, and they need to continue to talk.
Right.
In thinking, and this is doing, and all these things. Right. Connectivity is happening when brain is developing and continue to develop. So anything significantly impact that period could impact, but we don't have like a list of toxins that we think that is impacting. Another one thing is that people were worried about mercury and vaccines and things.
Right, so that's been ruled out.
Yeah, because of so much worry and so many people were afraid of that, there was large studies done.
Right.
And then compared the population who had a vaccine and not had a vaccine, and measured how many of them had autism. They did not see any differences. Right. So with lots of studies, that's been ruled out.
Right.
Yeah.
Can I ask a question?
Yes.
Yeah.
So it's not something that can be fixed, because it is a developmental neurological disorder, right? So it's because I think that being in the education community, sometimes they think that if we put a child here or do this, then it's going to fix it.
Right.
But technically, it's not something that can be fixed.
This is how I think. Brain continues to develop even after the child is born, right? And then what the child is exposed in terms of environment, education, affects a lot in how that brain develops. So we can definitely change a little bit of trajectory in some way. Can it be completely fixed or cured? That is even a question in a scientific society.
Right.
We know a very small portion of people in autism, small portion, will grow in college age. They go to college, they'll have a job, have girlfriend or boyfriend, and will not meet the criteria. They're communicating okay, their eye contact is okay, however, when they actually talk to them, you still kind of feel that there's some social interactions, not very fluid, a little awkward. So they still have characteristics, but because they function well and they also practice very much.
So there is some learned behavior.
Exactly, right. That's why the education and intervention, particularly early intervention, is really important. As I said, brain, so there's some impact in brain, either genetics or environmental, something happened, and then the connectivity is not really good, but that brain is still developing. Age 1, age 2, age 3, the developmental phase, our brain still develops until age 20. So if you can make those connections wasn't really better by teaching them, they can be much better. But again, the earlier you do that, the easier. Just like learning language. But you're right in a sense. Even though there's a small portion of people who do much better, you will have that. Okay, this person's understanding of my smile is a little off, or they do still have that characteristic, but they might not meet the criteria because they learned. To
so is it
kind of
ever
modulate
too late? Like, is it ever, even if, because now I know that they are diagnosing earlier, would that be correct?
Right.
So then the intervention comes earlier.
Yes.
So with that being said, if like for instance, in my case, there
Right.
was no early diagnosis.
Right.
And technically, educationally, we're just starting to connect the dots now. So is it ever too late for?
You know, that's kind of a little philosophical question. Too late will be really late. Like 7, you said that your child was diagnosed.
Right.
7 is not too late.
Okay.
Yeah, and even teens is not too late. I think because they're still learning, there's still skills teaching to be taught. But again, that age versus age 2, 3 will be, you know, pretty significant difference. And then let's say this person was mild case, never diagnosed, and at age 20, he realized, oh, like, or somebody else realized, oh, like, I meet all these things. It's just too late. I mean, in terms of like, again, changing trajectory, maybe,
Right.
but like understanding, oh, okay, that's why I was a little different.
Yeah,
You know,
yeah.
there's still some benefit of knowing what was
Right.
going on might be there, but changing the, you know, really a person's direction, you know, might not happen at age, you know, older
Right.
age. So,
Okay.
yeah.
So what is the, how common is it what is the prevalence? How
Right.
common is autism in the U.S. or worldwide?
Right. So each society seems to have like a little varied numbers.
Okay.
But as a whole U.S., as you mentioned, the prevalence has been going up. We have
Right.
CDC that has like 11 communities in whole across the United States. They measure at age 8-year-old.
Okay.
And that's been kind of number that we go by generally.
Right.
And that number's been going from 1 in 160 to 1 in 88 to 1 in 68 to, you know, so that's been going up. So since 2012 report and 2016 report been the same as 1 in 68,
right.
which is like unbelievably high number.
Yeah.
And then in boys it's like 1 in 42 or something like that, which means if you have 100 boys, there will be 2 boys will have this characteristic.
So maybe is it because we providers or doctors are more conversant or taking more, paying more attention, and or is it there's something in the air or something that we eat or drink that may be making it worse?
Right.
So
that's everybody's asking that question. That's like a, you know, really important question we need to answer. We know that I was talking to Ms. Ryan a few factors why it might be going on. Definitely, people are more aware of this diagnosis.
Yes.
Ms. Ryan said, like, she didn't even think about this diagnosis when he was young, versus now everybody know what autism is, and they everybody like think somebody knows somebody who has autism children. So the awareness of both parents and the clinicians, providers, improve the screening and, you know, catching the signs, right? So that definitely, so the catching the more people who weren't diagnosed, that is one factor. And another thing that we were talking, the children who were previously diagnosed something else before, either intellectual disability, learning disability, language disorder, now they can be more correctly diagnosed as this sort of constellation of symptoms and autism diagnosis. Is there something in environment, you know, again, that's harder questions to answer. There's lots of researchers study, okay, what about this, you know, chemical or this component, and maybe some small like animal study might show something, and then, you know, and when they do larger study it didn't show, or other lab does, it doesn't show. So we need like consistent large studies to show, okay, this is definitely having some impact. And in that sense, we don't have clear things, what's in the air it's making. You know, there are some concerns about it's sort of, what do you call this, pollution, making anything. There's some Asian countries have
very
recorded
high,
higher numbers,
I can imagine.
Things like that. But again, how are they diagnosing? What's their language, you know, cut off, and things like that. The diagnosis can be very between the reasons, and you know, things like that. So it's harder question to answer, but a lot of scientists are looking into those things.
Okay. Gender-wise, male and female,
Right.
what is how common is it
Right.
for males
Right.
compared to females?
So male is about 4 or 5 times more likely. So as I said, when we say 1 in 68 in the U.S., in the boys it's about 1 in 42. In the girls it's 1 in 189 or something like that.
Wow.
So about like 4 times.
Right, 4 times more. Okay. So what is the age of onset? When would a person, a mother, be looking out and say, okay, if kids will be kids, children will be children.
Right.
So at what point would a mother be worried? Say, look, I think my son or my daughter, something doesn't look right here. At what age would people get worried that their child may have autism?
That's an excellent question. And then, given what you said, like how late is too late kind of thing. I mean, what we know now is really the earlier intervention is better. When you think about why it's happening, right?
Right.
If you can kind of sort of try to rewire or reconnect that connection earlier, that's better, right? Because once your brain sort of developed, it's harder. What was your question?
So then the question was, like how early? Because little kids.
Right.
Yeah.
So that's the important question. What to look for and when you need to ask questions.
Yeah.
Right? So as I said, 2 things: social communication, right? Social skills and communication, and then sameness, right? Repetitive, restrictive. So if you see some of those, you gotta pay attention. So let's say, as I said, because it's a neurodevelopmental, they kind of do have tendency even very young. But when they're very young, it's hard to say, are they communicating okay? Are they do they have social skills? It's very hard to know.
Right.
It's very hard to know. But the researchers are trying to do earlier recognition, so that do something preventive. So younger age, like a 6 months, even 6 months and 9 months, 6 months through 9 months, you might be able to find something. So if parents see any type of developmental delay, the motor delay, this child is not really hugging you, it's just, or any no eye contact, such as if it's a 6-month-old, if you're like smiling and doing like things, then the child usually look at you and smile back at you, kind of thing. That doesn't happen. The child doesn't seem to be interested in, a child are craving for adults' attention, and you don't see that. And then like 6 months, 9 months, and then around 9 months to 12 months, the child explore the communication. They babble. They say, they try to say things, and you say back, and they say something back. Even though that doesn't make sense. Those type of communication type of things, babbling, saying words, are late. At least around 9 months, they should be like babbling, and around a year, they should be try to say some things like mama, dada. And if you don't see child not babbling around like 9 months or older, or not saying any words past 15, 16 months, then bring this to doctor's attention, with the pediatrician.
Yeah.
So at this point, we're not diagnosing autism, but we are catching the red flags or signs of developmental issues. And then after that group who are identified with the developmental issues, either communication or motor or social skills, like eye contact, looking me back, attention, things like that, then they are referred to the more detailed diagnosis, right? So for parents to kind of have, if the parents know the child, if they think that something's not right, or is this child late, I think you can ask questions. Don't feel bad of asking questions. Is this okay? My child is not babbling, not looking at me, or not seems to be really happy to be hugged. Is this okay? You can ask those questions.
So that's right. Yeah, just for you, when your son, you talked about, you have a son who has who has the same diagnosis as a little kid. Thinking back, question though, is he your first child?
No.
Okay, so you had some experience before. From what Dr. G is saying, did you looking back now, when he was a year, 2 years old, did you notice anything?
And that's maybe I can segue into, because those things you spoke of, those things seem to be on task. But there was something different. There was just something different about him.
Okay. The sort of quality of it.
Yes, yeah. like you really can't pinpoint it, but like he said words, you know, he would look, he would smile, but when you spoke of the repetitiveness, like he would repeat phrases over and over again, which I'm like, that's enough, but it seemed like he was developing normally.
Right, the meeting the milestones.
Right. Okay, yeah, because I don't like the word normal. Meeting the milestones, yes. However, there was always something different. So I want you, if you can, to speak on highly functional, because that's something that I have heard forever.
Highly functional.
Like he's highly functional, especially in the education community, because when we get a child, I guess, in the school system who is highly functional, it's very difficult to get them the services that they need, because although they're on the spectrum, they're not to that extreme to where, however, they still need interventions in different areas, especially in learning. Because sitting in a classroom with 20-something children, whether you're highly functional, you know, it's not making it. So if you could speak on highly functional, when you meet the milestones, however, there's just something.
Okay. So that's really a good question. So those children will be probably not picked up in very young age. In very young age, you know, they're talking and crawling and walking and talking, then okay, things are going. So it might be a little bit more delayed, and now you see quality of relationship and interaction with other people.
Right.
That's a social skill.
Right, because when he went to school is when things really started changing.
Right, even though you feel like, okay, something's kind of a little bit off, but can't really pinpoint, and then when they are expected to interact with other peers, peers are not that understanding as mother. So something's not quite right, then they might not be interested in interacting with that child too. And also, oftentimes autistic children don't seem to be very interested in engaging other children. So what you often hear, so you might not know if that child is the only child, or you don't really play with the child too long. Teacher might say, you know, so-and-so is doing good and grades are good, reading and, you know, answer questions. But in playtime, in the playground, he tends to go under the, you know, what's this thing? You know, swing or whatever his name. You come down, slide. Yeah, he'll just go under the slide and just like draw something, while all other kids are chasing each other and, hey, do this, can you do this? You know, that's the play, versus this child seems to be content without that type of interaction. So that's, and then you mentioned a very important thing. In that child, because his grades are okay, he's reading fine, then no services or people think that he's fine. I think important thing is the social skills. Again, those things you teach earlier, it gets more natural. Another aspect is learning style. You mentioned that the children is thrown into like other children of 25, you know, of other children. How are they learning? Because learning style of a child who even have like a good IQ, high IQ, can be very different. What we know, generally speaking, each children are very different, even with autism. But generally speaking, children with autism understand things more visually. Yeah, so pictures or demonstration with blocks, they're like really good. But if you say some long sentence or there's a page of, you know, paragraph, do this, then they get a little more confused. So if the child, even though the IQ is good, development is good, doing okay at school,
Right.
if the child is diagnosed autism,
Right.
and do a comprehensive evaluation, which will show, okay, he's good with the verbal skills, not verbal skills not good, but nonverbal is good, processing speed is good, like more
Right.
comprehensive evaluation might show, oh, I thought, this child is doing well, but this is really low,
Right, right.
which means he's really missing this area,
Yeah.
and then we can, kind of put more support in that area.
Right.
Yeah.
Right.
Okay. Well, but the sometimes we see the very sick patients with autism, and it's so hard to control them. I have some come to my office. You see that the mother or the father is holding the child so that they don't go down. There was one that I just saw her, and as they were leaving, and she just turns back, and she came to me, and she, oh, what are you doing? She's not verbal. She doesn't talk. So the question is for these very severe patients with symptoms of autism, how can the mother or the father, how can the family, what can they do? What can they do to help this child? But and you're going to hold on to that thought. We're going to take just a little break, and we'll come back. Guys, we're talking on autism spectrum disorder, autism, and today I have on the show Dr. G, who is an assistant professor with Hopkins, and also Miss Wright. Miss Wright is a school teacher and also has a child with autism. Don't go away. We'll be back shortly.
It was
So we're not on.
We are. Yes, sometimes.
Yeah, I think, that was really good. Like in terms of sort of repetitive and restrictive, I think I can talk a little more about that.
Yeah,
like, in
so.
that sense. And,
Right, because,
actually, when I answered your question, that would come
Right.
with it. 'Cause a lot of this behavior comes from that tendency to sameness, and change is difficult, and
Very
anything
much.
unexpected is difficult to cope and things like that. So.
Okay.
right, because medicine is like he needs to, even in your office, he'll survey, and then he'll go, we're next, right? Are we going to be next? Or he'll ask questions, like he'll say, where are we going? If I say, we're going to Chick-fil-A, so he'll be like, okay, do I know where it is? Which one? So he'll like name all the Chick-fil-A's that he knows, and I have to tell him which one we're going to. And if I don't go to that one, then
Right, he
things
doesn't. Yeah, he thinks he does. Right.
right.
It's very interesting topic. We have, so sometimes you have these people, there's no real treatment, just maybe some things to help calm them down, but we'll get into the treatment
Right.
part
It's
of it.
I guess it's a lot of intervention.
Yeah, we'll get into all that. Good. All right, guys. Welcome back to Dr. Gilead Show. We are talking about autism spectrum disorder, and I have Dr. G, an assistant professor with Johns Hopkins Medical School and Johns Hopkins Hospital. She is at Kennedy Krieger, where children with autism are treated. As a matter of fact, we have a patient together that we're always communicating, and today we asked if she could really be kind enough to come tell people about it. And also Ms. Wright, who is a school teacher and a mother of a patient that has autism. So you're welcome back. You can call on 301-429-89, 301-429-9247, 301-429-9247, or you can send me a text or on FaceTime and Dr. Theo Oswala, MD, questions and we can answer it. So, Dr. G, the two major presentations of autism, the deficits in social issues, also the restrictive, repetitive patterns. Can you talk a little bit more about these symptoms, so people can know what to look out for?
Right. So in terms of social skills, how they communicate and do back and forth communication, that we make eye contact, we use nonverbal gestures, those type of things can be either odd or sometimes not appropriate for the setting, such as a child have good skills and will say hi and how are you and things, but he'll say the same thing to the stranger or to the professor. It shouldn't be like hello, so the things that those are more milder cases where you need to modulate your social skills to the setting. They have difficulty doing that, and then again the quality of the relationship. Do they have friends, mutual friends? Because they sometimes say that this is friend, but the other person is they're friends, and then what's your understanding of being friends, and things like that. That the quality of, and then children have difficulty sometimes. Again, each child is different, and some child seems to not really interested in interacting with others. Those are more severe cases. A little less severe cases, children will want to have friends, and sad that I don't have friends, but don't know how to do that. And then because they say some odd things, or they tend to talk about the same thing over and over again, or they are more unidirectional. If I said something and you pause to hear like what other people say, they can't do that. So even though they want to make friends, they are unable to make it. So those relationships, language skills, and the verbal, nonverbal gestures and communication. Those are in the social skills RAM, and then the other repetitive, restrictive interest and behavior. As you said, the child can say like same thing over and over again, or what we sometimes call as like in medical language, it's echolalia. So you are saying something you heard. So you heard either mom saying or a television commercial said, and even they do the same intonation, of that, or cartoon. So that's more like severe case. What it sounds like is parents describe it like this. They have this film going on in their mind, and they'll say like random things, but it's a cartoon film going on, so you're talking something else, and this child will say something else. And those are kind of repetitive things, and then they have very restricted interest. So you said the Chick-fil-A, right? Like that was your child, right? Yeah. So it has this actually what we say is like high, that aspect, they're very highly intelligent, like memorizing something, particularly something their interest. That you said your child will know where Chick-fil-A in neighborhood and which one is where and all those things, something like that. We'll have a children who is really interested in light bulb, and they'll know like makers of light bulb and which year and where you can get it, how much is it, like all those things and things like that.
Like that about sports, like he knows all statistics. When anybody who's ever had anything to do with sports, he can quote what college they went to.
Wow.
So they can have very restricted interests. And I had a child who were really interested in fossil, and it was like 16-year-old, right? And then he has a collection of fossils. And usually 16-year-olds will say something, children or TV or something, but his conversation goes to the fossil. Whatever you say,
goes back to the fossil.
What did you do last weekend? Did the fossil.
Wow.
Like what do you want to be? Fossil scientist. Everything goes. And then even though the person wanted to say something else, wanted to talk about something else, they just cannot move that. And and as I said, sameness and other words that you can explain this as a rigidity. So mental rigidity. So something they have formed in their mind. It's very hard to move that. And you said we're going to go somewhere today, and it rained. And explaining that to a child with autism will be very difficult because you said that we're going and what's going on. And another thing is they have difficulty regulating that. So I'm upset. Well, most of the child say, okay, I'll give you like this, or let's play this, and you are able to work with it. But they're very difficult to focus. Before the break, you were asking the difficult behaviors. A lot of difficult behaviors comes from this rigidity. So, you know, we are school, so we had teachers, assistants, and one day assistant wasn't there, and that day will be, you know, very, very difficult.
So they can't manage change.
Right. Well, something's different.
Yes.
The same sense, like, I don't know, the food has changed, or they are going this route instead of this route today. All those things can be very different. And then I have this really liking this game, and that game was somehow unavailable. Those type of things. And then sometimes it's hard to even figure why. Just like another child was walking and just kind of swat at you. Really, it might be something going on in their mind and didn't go well. You know, it's very hard to even.
And the thing is, it doesn't go well. However, it doesn't appear as if they're able to verbalize that. Like, like I can say, like, I'm having a bad day because I woke up late and then my coffee wasn't ready. Like I can pinpoint all the things that led up to this moment. It doesn't seem like they're able to pinpoint where it came from, you know, what the trigger, so to speak, is.
That's absolutely right. So they have this sort of mental rigidity, so they get easily frustrated, right? So I get frustrated because this, but then another thing having difficulty is understanding emotion. That's kind of social aspect. So when you do this, people get sad. When this happens, people get disappointed. Understanding that is very difficult, so we teach that, but they're upset, but can't really think of, first of all, am I upset? You know, we usually know, but children of severe autism might not even aware that I am upset, and how can you think why I am upset when you don't know you're even upset? And things like that. So the teaching the emotion and emotional vocabulary and language, and try to indicate where you are in terms of emotion and feelings is one of the large part of education and skill training.
So we really ran out of time. So how do you treat this syndrome?
Severe.
How do you treat this syndrome? Overall.
Okay.
What are they? Because they have speech problems, they have hyperactivity, behavior problems sometimes. How do you manage such a child?
Yeah, what I can emphasize is, as I said, each child can be very different. So that your child need to be evaluated, right? And then the comprehensive evaluation will show weaknesses and strengths. So if it shows weaknesses, mostly social skills or verbal skills, you need, you know, social skills training or some training where you really teach eye contact, joint attention. You know, when I look at it, you look at it, and you look at me, and those things like teaching those skills. And second, if verbal language skills are really, really low, you need speech language people to do that.
So you need like speech therapists?
Yeah, speech language. So most of Autism Center, when they do evaluation, they will recommend, according to their evaluation, they will recommend, and we recommend speech language therapy, we recommend behavioral therapy, we recommend occupational therapy to reduce sensory sensitivity. Things like that. Those things that will make a recommendation, and then sometimes difficulties finding those services, right? And in a younger child, we have early intervention programs through the state program.
Like
under
what
3.
programs?
Yeah, under 3.
What kind of programs?
I think we have Head Start. Is that younger? I don't know the exact name of like a younger population. But when you go to the state, Maryland, early intervention.
They have Child Find, because we
Child
came
Find,
through Child Find.
Right. So there's a number of them. So
they'll test them, like he was like 4. like
Right.
3 or 4.
Right.
And he was tested to have some developmental delays.
Right.
And then, so what they did was, at the time, they gave him early intervention into like pre-kindergarten or
Right.
something like that.
Right. So, so there's two large, steps. Like first one, when they're before school, that's where early intervention comes. That goes through state. So you could go, search Maryland early intervention programs, and there will be a number of them. It's not just one. Yeah.
My pediatrician recommended a developmental pediatric evaluation.
Right.
So
Exactly.
from there,
Right.
from that, and it was through, I don't know what it was through, but it was a long time ago. But he got a developmental peds eval.
Right.
And then though that highlighted
Which way to go,
which
right?
way to
Yes.
go.
And then once the child is in the school, most of the treatment, a lot of treatment can become through the school system.
Right.
So individualized education plan, and that it might specify those type of treatment, like speech therapy, mental health therapy, occupational therapy, and things like that. And if the child is exhibiting difficult behaviors or other coexisting psychiatric issues, large number of autism children experience ADHD, attention deficit hyperactivity disorder, and also anxiety. Anxiety can be really high level of anxiety. So if the child is like really anxious about is this going to be going this way or that way, or worrying about is mom okay, school, a lot of worries, things like that, then you can treat with some anxiety medications. And if there's significant ADHD, attention deficit hyperactivity symptoms, then you can treat that. We do not have medication particularly fixed, really helping social skills or repetitiveness, the core symptoms. But we do have two medications that help severe behaviors, severe aggression, self-injury, severe destructive behavior, that we can use two of the antipsychotic medications are approved for those type of behavior.
What are those? Because I have some providers that are watching this.
Okay.
So
two that are FDA approved for severe behaviors in children with autism is risperidone and aripiprazole.
Okay, so that's Abilify.
Yeah.
So Abilify and risperidone are FDA approved for
FDA
autism.
approved for severe behaviors.
Severe behaviors.
Yeah. So because these type of medication also have side effects. So when the behavior is so severe, then it's better to treat even though we might have some side effects. So when you weigh benefit and risk, then benefits higher than you can treat. And another thing, more so than medication, that you really need to look for behavioral issues is behavioral treatment.
Like what do you mean?
Behavioral management. So a lot of people might have heard like ABA, Applied Behavioral Analysis, and basically looking this behavior as a sort of looking at the behavior and find out what's the function of this behavior? Why is this child doing, or what is child getting by this behavior, and really trying to change that dynamic by introducing alternative behavior, more acceptable behavior. So if the child is throwing things in the school because he can't do math and he doesn't want to do math, right? Then maybe we teach the child to say, I need help, or I need a break, rather than tearing the paper up, things like that. So those are behavioral treatment, and then also the parent teaching the parent when the child is doing this, which way of handling might be better, things like that. And then when the young child is having a lot of behavioral problems, what I really try to work with the parents is, again, a lot of things are coming from that sort of rigid mental thoughts and things. So when they're younger, when they're older, it's very difficult, but when they're younger and smaller, try to introduce more diversity Because a lot of times the parents, okay, my child likes this one and need to go this one. So a lot of obviously loving, supportive parents try to do that. So for 2, 3, 4, 5-year-olds, if the parents are so good at doing that, okay, right here what you like. Okay, we're going exactly this way because that's what you like. They might not have a chance to think about, okay, I don't like this, but okay, I have to do it. And then sort of developing that coping skills that they didn't have that chance for like 10 years. So at age 15, anything changes. He'll have tantrums.
Talking to them first. Like I've noticed, if we're going to change the plan, then I bring it to his attention prior to, because then he can start, and I'll say, like, get your mind right, because this is where we're going with this. And so, like you said, now he's about to be 16, but so he's adjusting to there might be, and sometimes he might even ask me, like when we're mapping, because he maps out things in his brain. So are we going here first, or are we going there first? So he can map it out, and if there's going to be a change, he likes to know ahead of time.
Absolutely.
So he's at the point now where he can ask me
beforehand. Yeah, that's awesome.
Question for you, Miss Wright. Now, you have this child, how difficult is it to navigate and get programs for how difficult was it to navigate the system, get treatment for him? I know that with such a child, you really need to be on top of things for him. How hard is it? So other parents can learn about this.
It's very hard. It was extremely hard for me, especially in terms of his education, especially because I was an educator. I was fighting the same system that was feeding us, so to speak, because it's difficult. I can't say anything, but it's difficult. But to anybody out there listening, trust your instincts about your child, and don't let that table full of people tell you what's best for your baby. But there are not a lot of services that I found. Maybe Northern Maryland has more things, but I live on the southern end, and the services are hard to find. I tried mentors and trying to find that big brothers and stuff like that.
Right, I know you talked to me about big brothers and all that.
It didn't work. But it's very difficult to find services. So just keep trying. And
so how did you get him into Kennedy Krieger?
It was years of getting him into Kennedy Krieger. It was years of getting him out of the public system into a private system. He went to a school for 2 years, and that didn't work. And what I was sharing with Dr. G was, she asked me, what did I like about Kennedy Krieger? And the one thing I like about Kennedy Krieger is they handle it. Like, they know who their audience is, and they deal with them appropriately. I don't get numerous phone calls. Like I told you, he had spent Friday in resource. I didn't even know he had spent Friday in resource. Like, he told me, like, I was in resource all day Friday because I don't like government, but we talked about it. But previously they would have called. I have gotten so many phone calls from the school, like, well, my journey. Right. But Kenny Krieger is there at the top of their game, and the thing, they handle it like they know their audience, and they deal with it appropriately. Like, that's all I can say.
Final one. So what would you tell a parent, just in one sentence, who has a child with autism? What would you
Take
tell
a deep breath. Get you a glass of wine in the evening and a cup of coffee in the morning. And tomorrow is another day. Tomorrow is another day. Whatever it is, it's not that serious. I mean, my son has punched walls, broken out windows. He has run in the middle of the street like I have. That's why I said highly functional.
Right.
Because on any given day, he's highly functional, and on any given day, he is at the other end of the spectrum. But tomorrow is another day.
Okay.
That's all.
Okay, thank you. Dr. G, you've really exhausted this topic. I have a few healthcare providers online here, but what is your final word for them? What should they look out for? What should they do? In just 30 seconds, we're running out of time. And also for our audience, for parents, family members,
For providers, I think that working with the school will be really important.
So working with the school.
Because if you see a child in the office and the parents report, you tend to kind of, okay, I got to do something or write prescription or something, but it might be really other things you could modify or change that can really help. I want to emphasize really teamwork, the school team, and behavioral management before jumping into the medications.
Okay.
Yeah.
So for the parents, anything you want to tell the parents?
You know your child the best, as you said, and then each child is different. So know your child, know the weaknesses and strengths, and try to find the services or teach the weakness that improve the weakness skill, but also foster the strength. As your child said, that interested in horticulture or something, and again, yeah.
Okay. All right. Thank you so much, Dr. G. I see that Falake joined. I also saw Candice, Shama, Prince Will, people from all over California, different places join. Thank you very much for joining. Today we talked about autism spectrum disorder, and our special guest today, Dr. G, an assistant professor with Johns Hopkins. Thank you very much. Thank you so much for coming. We really appreciate your coming. Thank you. And Ms. Wright, thank you very much. I'll see you again at the office. Thank you guys. And we'll be back here again Thursday next week, and we'll talk on another important topic. So stay tuned. And this is there. It'll be online. Look at it, review it, send it out. People will hear, and other people will benefit from it. Thank you very much. I'm your host, Dr. Theo Oswala. I'm a psychiatrist. And right there, my office is on Annapolis Road. Phone number is 301-577-9111. You can call, set up an appointment, and we will do the best we can to help you. And if there's need, we'll refer you to Dr. G and Kennedy Krieger. Thank you very much. Thank you, everybody. Thank you for tuning in.
Thank you.
Thank you.